Welcome. Good morning here in America and good afternoon rest of the world. And welcome to, this is our Ifso Journal Club. This is number 35. And we welcome not one, but two speakers, two presenters. This is a very special occasion because we have two presenters. And we welcome you, Dr. Mohammed Hani and Dr. Bat Resma. Today, we are talking about a very special presentation. The paper, it's called Revisional Roux-en-Y Gastric Bypass versus Revisional Modern Anastomosis Gastric Bypass after failed sleeve gastrectomy, a randomized controlled trial. Our presenters are Dr. Mohammed Hani. Dr. Hani is an associate professor of the Department of Surgery and Medical Research Institute at Alexandria University in Egypt, and a consultant of bariatric surgery at Medina Women's Hospital, who is as an Ifso Center of Excellence in the European chapter. And Dr. Bart Resma is a PhD in clinical epidemiology and bariatric surgery. He's working as a consultant in an epidemiologist and data scientist, full-time collaboration in medical research in the Institute with Dr. Hani, and is home-based in Leiden University Medical Center in Leiden in the Netherlands. So Dr. Hani, Dr. Resma, welcome. We're very pleased to have you. Your paper is great. Congratulations in the effort of doing a randomized controlled trial in something that is very thrilling for us, that is everything related to weight regain and trying to overcome these kind of issues with our struggle dealing with this complex problem that is obesity. Welcome, guys.
Welcome, Doctor.
Thank you very much.
Thank you very much. We are pleased to be here with this esteemed committee, and we are delighted to present our work with you.
Thank you. Let me remind you, this presentation is being recorded. So you can watch it later in the future in our Ifso channel and our Virtual Academy. And remember, you can send us questions and you can type it in your question box. And we will ask these questions to our speakers later after the presentation. So we will begin with our poll question. And let's see the question number one. Question number one is, the commonest revisional option after failed sleeve gastrectomy is anastomosis gastric bypass, Roux-en-Y gastric bypass, re-sleeve gastrectomy, biliopancreatic derivation or duodenal switch, or a sleeve duodenal bypass vertical as SADIS. We will give you 1 minute to choose your answer. Great. So we have a little amount of time, so we need to be quick. And let's begin with the presentation. This paper is very special because we have two experts in two different areas, epidemiology and surgery. So we will begin with Dr. Bart Resma, who is an epidemiologist, and he built the methodology of this paper, and he will present us the way he and Dr. Hani built this paper and how they managed to build the proper way to deal with all the variables and the way to construct this paper. So Dr. Resma, welcome and thank you for your time. And one more time, welcome. And
thank you very much for your introduction. Because I'm now also with Dr. Hani in Egypt, we already recorded the presentation from my side. where I will shortly highlight the methodology framework. And please let me know if you have any questions afterwards over the chat, or afterwards we can answer this nicely by email. So Sebastian, if you can start my pre-recorded video, that would be wonderful.
Okay. So you are ready for your next? Yes.
Good afternoon. This is Dr. Bart Torsma. I'm a clinical epidemiologist working together with Dr. Hani, and we have a collaboration whereby we want to conduct studies, whereby we also always give an extra attention to the methodology ground of all the research. In this case, we did also together a randomized controlled trial, and I will highlight two small things what I think and we thought that would be interesting to this study. First of all, randomization. We know the principle to prevent selection bias. What we extra did is a randomized block randomization. So normally we have always equal blocks of 4, and it can be AABB or ABAB, etc. But at a certain point, there is always a possibility of allocation bias. And you know at a certain point what kind of treatment someone's got. To prevent that, we use randomized block randomization. So we have several block sizes from 2, 4, or 6, whereby there is a possibility, if you, for instance, have a block of 6, that you have AAA, BBB, and then a new block will open, and that can always start with, for instance, the treatment B. Therefore, you have no understanding anymore what is happening with the randomization. You have almost zero selection bias, the allocation bias is gone, that as well. Then blinding. Okay, blinding has also a part of selection bias. We want to prevent confounding by indication. We want to prevent measurement bias for the possible placebo effect. But we thought about something else, and this is specific for this treatment of this study. We have the OHEB versus the gastric bypass. And we know that when you meet a patient, you can always say, okay, the classic is the gastric bypass. We have now also the OHEB, and you have a possibility to maybe lose a little bit more weight. We know in bariatric surgery, especially with patients with obesity, motivation is essential. So what we now did is, normally you would maybe not blind a treatment. And in this case, we did. It was a single blinding, single in the way that the patient was blinded, the outpatient nurses were blinded, but the surgeon, and in the end, after the analysis, the data was captured, I was not blinded in full. But what we tried to do is to have a prevention of confirmation bias. That is the bias on the treatment outcome. So where you can say, oh, this treatment has a possible benefit compared to another treatment. And if you know if you've got that treatment, you are willing maybe to motivate more to lose weight. By now blinding the treatment, the patients did not know for 2 years long if they got a bypass or an OHEB. And that made that the first things in the result that there was an equal amount of weight loss in both therapies. This could be a new part of looking at how we can do research, and looking forward also in the Q&A session.
Thank you, Dr. Renzma.
You're welcome. Thank you very much.
Now it's time for Dr. Hani to talk about the results of all these efforts and all way to manage all this data that Dr. Torrensma magically managed to get, because when you are talking about AB and AAB, ABBB, and we lost us with all these to manage bias, well, then the results make us see how this methodology works in the results. So let's go with Dr. Hani and the presentation about the results.
Thank you for a nice introduction. Please share my screen.
Good morning. Good afternoon, good evening, wherever you are. I'd like to thank the Ifso committee for allowing me and my team to join the Journal Club. Today, I'd like to present our work, revisional Roux-en-Y gastric bypass versus revisional one anastomosis gastric bypass after failed sleeve gastrectomy, a randomized controlled trial. Due to safety, relative technical ease, and good results, sleeve gastrectomy has become the most common bariatric procedure worldwide, accounting for 45% of all reported bariatric procedures. However, many patients undergo secondary surgery mainly for inadequate weight loss and reflux. And with the current rate of laparoscopic sleeve gastrectomy being performed, many patients are at risk for future revisions. Previously described techniques include RYGB, OAGB, SADS, biliopancreatic diversion with adrenal switch. Although these procedures have proven their efficacy as primary options, evidence regarding their efficacy and safety following sleeve gastrectomy for either indication is scarce. Primary OAGB is currently the third most common bariatric procedure after sleeve gastrectomy and RYGB. The safety and weight loss of OAGB were reportedly equal or higher than those of sleeve gastrectomy and RYGB. To our best knowledge, no published randomized controlled trials have compared revisional RYGB and OAGB as post-sleeve gastrectomy options. We aim to compare the outcomes of both techniques after laparoscopic sleeve gastrectomy in terms of weight loss, occurrence of complications, resolution of associated medical problems, and nutritional assessment over 2 years of follow-up. And while every type of surgery had an impact on GERD symptomatology, we excluded patients with higher grades of reflux. Study design, the single-blinded randomized trial, we recruited the patients between August 2018 and February 2020 at 2 specialized bariatric centers, Medical Research Institute and Medina Women's Hospital, Alexandria, Egypt. We included patients aged between 18 and 60, and weight regain was defined as increased weight above the nadir was reported by the patients, or BMI above 35. We have here the mean BMI was 45 kilogram per square meter, and we excluded patients with higher grades of reflux. Endpoints, as we said, weight loss, occurrence of complications, nutritional lab test results, resolution and improvement of medical problems over 2 years. Derivative data such as patient demographics, body mass index, time between primary and revision procedures, associated medical problems, endoscopy and imaging findings, and sleeve volume was assessed by multi-detector computed tomography, virtual gastroscopy. Lab investigations were collected. Furthermore, an assessment by multidisciplinary team of dietitians, psychiatrists, and medical bariatric surgical nursing in the outpatient clinic was done. RYGB and OGB were performed by the same surgeons, 2 main surgeons and 4 assistants. And they will try to give some short videos, try by exploring the abdomen, then try to dissect the adhesions around the pouch. So we need to, half of the patients here at least have hiatal hernia. So if every patient here, we dissect the hiatus and see both crural pillars evident, and we closed the crural pillars with non-absorbable sutures, barbed suture. And in RYGB, we created a small pouch. Tried not to dissect to have good blood supply for the pouch. Now the pouch is created. We open a gastrotomy here to receive the intestine. We counted the intestine, a count of 5 with calibrated instrument. We have here in room Y 100 biliary limb and 100 alimentary limb. And in the mini, for one anastomosis gastric bypass here, we have 1 measurement, which is 200 centimeter. And here the bypass length in both techniques are the same. The pouch is created. Here we create the anterior enterotomy here. After closing the enterotomies, we will close the defects. We have many techniques to close the defects. Here we use the non-barbed in one. This is one technique of ours, non-barbed suture, non-absorbable suture. To avoid loosening after the patient loses his fat and if defects become widened again. This is the Peterson defect. Also, staplers is one of the techniques described in the literature, and you can do it according to the results you have. We have one case only of internal hernia in this cohort. And now we test the pouch for leak, and that's it. Also avoid to leave a huge candy can beside you. It is the most important thing that you need to calibrate your pouch again, because some examples here, if you can see here, you are not allowed to see something like this and leave it. It's not right to leave something like this. So to avoid this, because the patients here, we have a good food tolerance because the tension inside the stomach becomes less. And also avoid leaving bucket like this, which will contain acid. Postprandial acid containing bucket is something that is reported in the literature. It's important not to leave this behind you. It's also extensive adhesions, and see this pouch, the stomach, how large it is. It's something crazy. You need to resize all this. Examples of recalibration is necessary to achieve a good weight loss. Don't leave this beside you because this is not also a SADI. Post-operative care, we give routine prophylaxis against venous embolism to 12 hours before surgery, and will continue for 21 days after surgery and maybe 1 month for some certain cases. Gastrocnine swallow is routinely done on the first post-operative day, and also we do a CT with IV and oral contrast with alarming in patients with alarming symptoms like persistent fever, abdominal pain, vomiting, something tachycardia. This is an important thing. Endoscopy is not routinely done after surgery except when there is a complaint of reflux, regurg, bilious vomiting, interruption of sleep, melena, dyspepsia. Multivitamins, calcium and iron supplements were prescribed to all patients. This part of the study, I will leave it to Dr. Bart to discuss and describe the design of the study. During the patient's enrollment, we have 294 patients with previous sleeve gastrectomy. 26 were excluded from the study for being older than 60, and 92 patients were excluded for having GERD, grade B or higher. Study included 176 patients, and with loss of follow-ups, we have 80 per arm, and we have one patient at the end of the study refused to share her data with us, and we analyzed 80 at the end in both groups. No significant differences were found in baseline characteristics, including demographic data, student medical problems, pre-revision imaging, and lab results. The mean age was 43 years, and mean BMI was 45. Also, we noted the rate of hiatal hernia is important that we must correct it with the surgery. Operative time was significantly lower in the OHGB group than in the row Y gastric bypass. In total, we have one patient with incident of leakage at the esophagogastric junction. In each group, we have 2 cases of bleeding, or partial portal venous thrombosis occurred once in the OHGB group, no mortality between both groups. In our OHGB group, internal hernia occurred once, marginal ulcers occurred twice. Bursitis hernia was detected in both groups. Post-operative endoscopy, we have one de novo GERD in RYGB, while bireflux was diagnosed in 2 patients in the OHGB. Post-operative lab values are similar between the 2 groups. Hemoglobin A1C and calcium levels were significantly different, but these differences were not clinically relevant. Regarding the BMI loss, timeline and percentage of excess BMI loss, a mean time between sleeve gastrectomy and revision was 5.9 years. The BMI after laparoscopic sleeve gastrectomy was 30.9 in the OG group and 29.8 kilogram per square meter in the RYGB group. In both groups, BMI significantly changed after revision surgery. At 6 months after revision, BMI values in both groups were significantly higher than their nadir values at 1 year. At 1 year after revision, BMI values were lower than their post-sleeve gastrectomy nadir values in both groups, with no statistically significant difference. At 2 years of revision, both groups showed significantly lower BMI values than their post-laparoscopic sleeve gastrectomy nadir values. In the percentage of excess BMI loss, we have 6 months after revision surgery, this percentage in the OAGB group was significantly higher than in the RYG group. However, the differences between the two groups continued to decrease and were no longer statistically significant at 1 year and 2 years. Associated medical problems in comparison to the preoperative period, both groups showed significant improvement or resolution of diabetes type 2, dyslipidemia, hypertension. However, no significant differences between the two groups were observed. Weight loss failure and weight regain are commonly reported long-term sequelae after bariatric procedures, with higher incidence among restrictive procedures such as sleeve gastrectomy. RYGB is the most commonly performed revision procedure after failed sleeve gastrectomy. This observation may be due to satisfactory weight loss effect and less serious nutritional deficiencies and improvement of reflux. OGB is still less commonly used than RYGB after LCG. However, the popularity of primary OGB has grown over the last decade due to low complication rates, in addition to similar technique, shorter procedure time, and shorter learning curve. In this study, both OGB and RYGB groups showed significant BMI reductions after revision surgery. In addition, both groups achieved BMI values that were significantly lower than their post-sleeve gastrectomy nadir BMI. The weight loss effects of both groups were almost equal. Data available from some retrospective comparisons of both techniques showed significantly higher weight loss effect in the OGB group than in the RYG group. However, other studies have reported similar weight loss effects with both procedures. This may be due to length of the biliopancreatic limb in the OGB. The relation between the length of biliopancreatic limb in the RYGB and weight loss have been a matter of debate in the literature, while the main objective of the surgery to achieve weight loss and avoid nutritional derangements. At the same time, the data available from the studies and systematic reviews refer to the higher weight loss with longer biliopancreatic limbs. Data from large volume prospective studies reported no significant differences between longer and shorter biliopancreatic limbs and weight loss. The same debate exists in the OGB, while some authors use a fixed biliopancreatic limb length of 200 cm, whereby other authors recommend biliopancreatic limb length of more than 150 cm to avoid severe malnutrition. Moreover, some authors propose tailoring of biliopancreatic limbs in RYGB and OGB. In this study, we recorded excellent weight loss and nutritional laboratory values between OGB group with 200 cm biliopancreatic limb length and the RYGB group with a biliopancreatic limb length of 100 cm combined with 100 cm elementary limb through 2 years of follow-up. There is an interesting study here of Mahawer et al. Performed a recent systematic review evaluating the effect of different limb lengths of RYGB on weight loss. In contrast to what would be expected, that the bypassing longer small bowel length would be associated with a more malabsorption and superior weight loss. The findings of the review confirmed that the malabsorption does not make an important contribution to weight loss, and they attributed this to that the bypassing the jejunum is the responsible of the weight loss. However, also there is multiple studies related to the raw limb, and one study, the Dutch study, Ducati, started randomizing patients with very long elementary limb, raw limb, versus short one, and the midterm follow-up there was significant weight loss with the longer row limb. The evidence is supported also by Stefanidis et al., who reported that the longer row limb may benefit the super obese, but unlikely those with a BMI below 50. The mean operative time in the RYGB group was significantly higher. OGB is a simpler because it's one anastomosis. The simplicity is also an important issue, as some surgeon would prefer re-sleeve, which is this technical demanding technique, over RYGB for failed sleeve gastrectomy, despite the questionable effectiveness of the long weight loss maintenance. The overall complication rates were comparable between OGB and RYGB groups in this study, which was consistent with previously published data. The study have one leak in the RYGB group at the esophagogastric junction, which is managed successfully with a self-expanding metallic stent. Bleeding required intervention occurred in one patient in each group. From momentum, internal hernia occurred in one patient in the RYG group, despite routine closure of mesenteric defects. Also, though no guidelines have not been edited advising routine closure of mesenteric defects, in this study we have one. It should be noted that there is an increased incidence of immediate small bowel obstruction, also due to kinking of the jejunostomy that was clearly linked to the learning curve of the surgeons since the first seminal paper by Hega et al. Published in the year 2000 on complications of RYGB, highlighting the need of routine closing the defects. Almost 20 years later, this issue is still a matter of debate. In 2006, an exhaustive review of literature indicated an internal hernia may happen and over only 2 years later, in 2016, Stenberg et al. Proved in the randomized trial that non-closure results in increased rate of reoperation. The association between GERD and severe obesity is well documented. Hembes et al. Have shown that the rate of de novo GERD occurrence following laparoscopic sleeve gastrectomy is estimated at 20%, although RYGB has been traditionally considered the gold standard surgical management of GERD with acceptable short to mid-term results. A large long-term nationwide study by Holmberg showed that 15% have recurrent GERD at 10 years. In both groups of this study, all patients with symptomatic reflux before revision had their symptoms relieved after their procedure and stopped their medication. De novo GERD grade A was diagnosed in one patient with RYGB, while bireflux was diagnosed in 2 in OGB. While the long-term impact of OGB on GERD is still unclear for both primary and conversion surgery, we here have excluded the patients with higher grade reflux. Stebar reflux remains the predominant cause of reoperation following OGB, and despite the inherent concerns about the reflux after OGB, evidence from large OGB series has shown that the incidence is lower than first feared. Diagnosing bireflux is all challenging, with no single investigation deemed superior to another in systematic reviews. The most promising study is the biliary scintigraphy with modification tailored to the anatomy of this surgery, and also combined with upper GI endoscopy with the visualization of the bile. The incidence of our study was 2.5 without need for reoperation. For bireflux, we used doctoralfate and also deoxycholic acid with successful outcomes. Several surgical solutions are available when medical treatment failed, like conversion to RYGB, prone anastomosis, and dividing the efferent limb, reanastomosing it to the efferent limb downstream. And here is one interesting study concerned about conversion when you have reflux. They used pH impedance monitoring, which is important to differentiate between bile and acid. When you have acid or mixed reflux, so you need to convert it to the short biliopancreatic limb, RYGP, if you have biliary reflux or no reflux. So you must look for the nutritional deficiencies and disabling digestive disorders. And they are present, you need to convert it to short biliopancreatic limb, RYGP. If not, so you can distalize the afferent limb and convert it to long biliopancreatic limb, RYGP. And these are the techniques of long one and short one. Here also in the short limb, biliopancreatic limb, you may need to resect the anastomosis area if you have structuring or kinking or something like this. In this study, marginal ulcers were diagnosed by endoscopy in 2 patients in RYGB and no patients in OGB. Medical treatment was effective in both patients. The reported incidence of marginal ulcer in the literature was approximately 4.6 in RYGB and 2.4% in the OGB. Different risk factors have been advocated to be a causative agent of early versus late ulcers. Early marginal ulcers is believed to relate to the local factors that inflammation as well technical aspects. And late marginal ulcers are treated with underlying risk factors for microcirculatory damage. Our observed rates were lower than reported. However, endoscopy was performed only for patients with symptoms, and maybe we have missed some of the ulcers. Both groups in this study experienced comparable resolution and improvement of associated medical problems like dyslipidemia, hypertension, and type 2 diabetes. Consistent with our findings, previous studies showed the same results. Also here we have these studies, Omega and Order trials. We have some superiority of OGB in relieving diabetes, and also we agree with the authors that not the bypassed limb is responsible, but also the gut hormones theory is one is responsible. Like we have stimulation of GLP-1 and BYY. The 2 hormones have promote insulin release and they inhibit glucose secretion and inhibit gastric acid secretion and acts on the CNS to decrease food intake. Lab nutritional values were comparable in both groups in this study. Patients in both groups were prescribed the same multivitamins and minerals. We also have a Omega trial that reported despite comparable weight loss and resolution of metabolic disorders, prevalence of adverse events was significantly higher than the OGB group. Also, we have no patients here with preoperative nutritional deficiency. The most common nutritional disorders observed in our study following both bypass surgeries were B12 and vitamin D and iron, ferritin. Regarding the optimal procedure for patients with weight regain or weight loss failure with GERD grade A, both OGB and RYGB show good outcomes for weight loss and incidence of de novo GERD or marginal ulcer. However, longer follow-up is needed. To our best knowledge, this is the first randomized controlled trial to compare both techniques as revision procedures for weight regain after laparoscopic sleeve gastrectomy, but we have some limitations. A larger sample size is needed, short-term follow-up of 2 years. Patients with higher grades were excluded. Routine endoscopy is not attempted after revision, resulting in possible missing data regarding GERD and marginal ulcers. Differentiation also between the both type of reflux needed more techniques. Data about smoking cessation was not recorded. Many of the data of the preoperative regarding the original laparoscopic sleeve gastrectomy is not available because half of the patients are not mine. In conclusion, both revisional RYGB and OGB had comparable significant weight loss effect when performed for weight regain, with comparable resolution or improvement of medical problems. Given the advantage of being simpler and easier, OGB may have a greater chance of being the optimal revision procedure if longer follow-up data are available. After 2 years follow-up, both procedures were safe, with no significant differences in the occurrence of complications and nutritional deficits. Thank you.
Thank you, Dr. Hani, for a great presentation. As you said, this is also, in my knowledge, the first RCT regarding a comparison between OGB and gastric bypass after a sleeve gastrectomy. Well, first of all, before talking about discussion and some Q&A, let's see the results for our first poll question. And the results are these ones. 73% of our audience see the Roux-en-Y gastric bypass as the commonest additional option after a failed hysterectomy. And in second place, the OIGP. In third place, the SADIS procedure. After this presentation, let's put this question one more time, and let's see if our audience change. So the same question, is the commonest revisional option after a failed sleeve gastrectomy? OAGB, Roux-en-Y gastric bypass, re-sleeve gastrectomy, biliopancreatic diversion or duodenal switch, or SADIs. We'll give you 1 minute.
Posso chiamare un'altra volta? Un attimo, mi devo delle istruzioni.
Okay, let's see. Well, changes a little bit. So, with 65%, Roux-en-Y gastric bypass remained as the first option for a revisional surgery after a failed sleeve gastrectomy. But when anastomosis gastric bypass rises a little bit as a 30% as an option for the failed sleeve. Re-sleeve get a 3%, and biliopancreatic diversion also a 3%. It's an interesting finding. Roux-en-Y gastric bypass and OAGB remain the two main options. That's interesting. Well, let's talk with our two speakers, Dr. Hani and Dr. Terenzma, and we have a couple of questions for you both. First, for Dr. Terenzma, we have a couple of questions about methodology. Dr. Abdelasim asked Dr. Bart, first, in retrospective studies, what kind of bias given?
Sorry,
In retrospective studies, Dr. Bart, what kind of bias were given? I think it's talking about in general.
In general.
Studies.
Yeah, well, first of all, the problem with biases is that if you do not measure it, you cannot correct for it in the form of confounding. We have always the good possibilities of propensity score matchings. And in this case, what is important, what the bias could be in a retrospective way, is what I talked about with the confirmation bias. And so if a patient has an OAGB, whereby you have on the forehand the motivation talk of this could be a very well funded treatment for you, maybe better than the classic Roux-en-Y gastric bypass, what we will do in the past, that this possibly will help in a better outcome afterwards. Also, knowing when you as a surgeon want to give a patient to a treatment, the same confirmation bias works also for the surgeon, because if you know that the treatment effect would possibly benefit you, possible easy, it will help you in convincing the patient to do so. And in this randomized control trial, that was not possible, and therefore, well, the results speak as they are. It can help.
Perfect. The next question, you can answer both because it's talking about the single blinded topic about your research. Who among the team was blind? I think it was this was the surgeon, right? Or it was the surgeon who was blind in the team?
No. So in this case, what we wanted to do is, first of all, it was not common to blind at all, but we wanted to add this layer for more confidence in the study results. So the patient was blinded and the outpatient nurses were blinded who do the measurements of with the patients. So what you will get is that the nurses also did not know what the treatment was, so there is no conflict of confirmation or any type of bias. And the surgeon was unblinded, and he got the allocation code after the patient was on anesthesia. And I was not blinded when I was receiving the data set. And in the future, you could say that maybe could also be blinded. But for now, we kept it with the patient and the outpatient nurse clinic.
Great, perfect. Very interesting. Yes, thank you for your answer. And another question is about the anesthetic management. We know anesthetic management plays a very important role in the integrity of the anastomosis in the surgery. So the gastric anastomosis technique and the drug used during the surgery was unified in the whole cohort.
Yes, I think this is an important question. But for me, as a surgeon, what's important for me during the technique and how I can communicate with my anesthesiologist? First of all, we have the same team of anesthesia with us, okay? So more or less, the drugs or the technique is the same. But for me, when I'm doing stapling, I'd like to see the blood pressure sometimes not low. This was proven in the literature also. You need a good blood supply at the edge, so you don't need to, the patients have low blood pressure. This is must concentrate on this, and my surgeon during stapling. Sometimes when you miss something that you have no bleeding in the stable line, you try to search for the blood pressure. If it's low or not, or it's normal or not. Something else also is important at the end of surgery to maintain the blood pressure that the patient have entered during the surgery. Something else with the communication with the anesthesiologist is the movement of calibration too. Something important, not to miss or put NGT at all, because you have many accidents that you may stable this. This is what I need from my anesthesiologist, and at the end of surgery, you need to lower the blood, to raise the blood pressure and deflate the abdomen and insufflate again, see if you have any bleeding points or not. This is what the important aspect for me, so we could communicate with my team, and also something else in the post-operative period recovery that you must use something like the analgesia and use something like rapid recovery, like Sugamma and something like this. It's an important thing that I need from the anesthesiologist side, which concept to my work. But maybe there is another technique or something I maybe I don't know, cannot answer or cannot get it from the question, but this is what I can answer to now.
Thank you, Dr. Hani. Once I was watching your video about the different ways you perform your procedures, you show us different scenarios about different sleeps. And when I was reading the paper, I noticed that you talk about sleep volumes. Did you find any value in doing these studies about volume, and this volume of the sleep have any importance in doing the comparison between population, between the patients, between Roux-en-Y and OGB and the results after the surgeries?
Yes, something important. When you have the patient with weight regain, you need to study two things. The first, the anatomy of the surgery and the behavior of the patient, right? Okay. And if sometimes you find the anatomy of the surgery is good and everything is going good, so you need to concentrate on the other aspects, because you don't need that these patients after the surgery again will hang over your neck and you tell me that I am not losing weight. Why? Okay. So you need to choose your patient well. Okay, but this mode will not differ in technique. If you will do Roux-en-Y or one anastomosis, you need to calibrate the pouch. It's a must, I think, because if you leave it wide, the patient will eat well, because the tension inside the pouch will be less. And he told me that I am eating too much before I did this surgery, I was eating lots. So how I can lose weight again? Okay, so you need to calibrate this. When you work a lot, you will see that this is of benefit. It's utmost important. And also, when you leave bucket like this, it will contain acid also. So the acid area, secreting area, has become more, and you have exposed the patient to reflux after this, because this is postprandial, will collect food and acid, and also you can expose the patient with more acid that can do a marginal.
Yes, it's very important. When you train young surgeons and you explain to them like revisional sleep, it's it can be very easy to do or very hard to do, depending if you want to do it properly or not. And to trim again the stomach, it's a must. So if you find stomachs like that, this is very important, and it's very good. It's very important for our audience to get images like you show them of those stomachs, very dilated and very complex sometimes to trim, and it's a very valuable lesson, and also to show them like it needs to be done if you want good results. Another important questions about those margin ulcers that you got during your in this cohort are very interesting findings, because you got more ulcers on Roux and White than in OGB. So this like
Yes.
this you will think like it will be the opposite. So
Yes.
you have some theories about that, like why, technique, sutures, the patient itself. What are your thoughts about that?
Yes. First of all, maybe you have one limitation here, that the smoking and the behavior of the patient is not recorded well. Maybe one factor. Okay. The other thing, maybe now we use the same sutures here, the same kind of stapler here, linear technique and something like this. So maybe this is not the one that's responsible about this ulcer. But if you find or read in the literature also that some studies that reported that RYGP also have a kind of ulcers more. Why? Because it told us that the area that's secreting acid is from the cardia till the angle of it, so till the incisor angular. And this is the most concentrated part of acid here. Also, when you find the perforation of the martial ulcer, you find it medial always in the RYGP, rather than lateral in the one and small gastric bypass. So this area is still secreting acid in some. And for some reason also that you had some reflux in RYGP for several theories, like peristalsis of the pouch, in the hyporeflexia in the lower esophageal sphincter and something like this. And you have some still acid that does not go well inside the pouch, or the transit of it still is present inside the pouch. So you have many theories, but you cannot have one certain cause why this occurs. And also, if you'd like to be sure that this is the right thing, you must do endoscopy at certain time for all patients.
Perfect. One interesting question, why didn't you make sure that the anastomosis was the same for all the patients? So why do not make it with a circular stapler for your trial?
Yes, okay. So, one clear answer here, that still we have no use of this circle stapler during our learning curve or something like this. I've seen many surgeons doing this. Okay, they can create a micro pouch with a circular stapler, but still some debate about this, that it can cause also marginal ulcer. Okay, but for me, I still from my learning curve and experience, I didn't use them at all. But maybe we can try this. If we find problem in our technique and results, we may change the technique. But our technique can have good results and low complication rate. So I think it's not a matter of how we can change it or not. It's not an important thing.
I agree with you, Dolph. I agree with you. Did you find any relation between the shape of the sleeve before the revision and GERD after the revision?
Yes, GERD, we have improvement in GERD in many of the patients that have already. These patients have a lower magnitude of GERD, this is GERD class A. Some of them abandoned the drugs they have used yet, and we have de novo in one case, in Roux and White also. Okay, so I think this is an important thing, that the GERD will improve after surgeries due to rapid transit and decreasing the surface area of acid.
But did you know if that de novo GERD patient was a twist sleeve or a bad shape sleeve before this revision? Do check if that de novo GERD patient had a bad shaped sleeve before?
Yes, these patients already have a huge bulge still in the upper part of the fundus, that you say. Okay, but after surgery we trim it, yes, but still maybe you have some problems with the motility or something like this, and it's still present. The reflux is still present. Because also we didn't,
already.
Because also we didn't study the pattern of the motility with the impedance or something like this.
Excellent. Dr. Hani, there's a lot of evidence and lots of change of evidence during the last 40 years about limbs and lengths and alimentary limbs, and then we changed to iliopemphatic limbs. But you did 100 and 100. Why?
Yes, because I tried here to be at the bypass segment. Here is the same, more or less, is the same between. Okay? But when we started at the past that we are working with the standard 65 to 60 and 150 elementary limb, we did find a good result. Yes, okay, we know this, but you have now an era that told you that when you length the bilipancreatic limb, like OHV, you will find a better result. Okay, so we tried to lengthen, yes, the biliary limb without compromising the nutritional deficit. That's good. So we have decreased a little bit the elementary limb, okay, to have a more common channel, so to avoid malnutrition and at least to make them what to have bypass. Yes, similar, and the technique is standardized between the cases. Yes, okay, but for me, if you can, we can try another thing. We can measure the whole bowel. We can make better studies more than this. Okay, we can do this, but this is what our idea. And also we have used 200 centimeter in OHB, and we have some literature now and some knowledge that you can achieve the same results in 150, okay, centimeters. But we use this because this is a revisional case, you need to bypass more at least, okay, to achieve more or less a better result. And also the available literature in the randomized trial in the OHB used 200 centimeters.
Perfect. Dr. Hani, for me, your paper was very interesting and it's very valuable for one thing the most. There are lots of young surgeons who are beginning practice, who are struggling with revisional surgery because the sleeves are everywhere. And Roux-en-Y gastric bypass requires ability and requires experience. So OGV is a more feasible, a more a less technique demanding procedure. So your paper shows us that OGV can be an option. But what's your advice for young surgeons who need to do revisional surgery after a failed sleep, after doing this paper?
Yes. Remember one thing, one important thing, that you can change your decision inside the OR. Okay, so you don't do a revision surgery without knowing the whole technique. First of all, you must master everything before you go in this. So you must have one backup with you when you are trying to learn this surgery. You must do all the surgeries by efficiently to can manage anything that we have emerged inside. Yes, one smooth gastric bypass is simpler and achieve a good result. Yes, but not suitable for all the patients. Yes, if you have the endoscopy of the patient before the surgery and you find a bile inside the stomach, so how you can do one smooth gastric bypass? No, you think you will need to do a raw. Even you find you haven't any evidence of reflux or symptoms, you may will appear with ears. So another thing, that if you have patients with a higher grade of reflux, okay, so it's advisable to do one smooth gastric bypass. No, it's still not proven. For the young surgeon, you must master all the things. Nothing called easy surgery. No, every surgery has trick his own or her tricks. So you need to master everything. So you will face many things inside the OR that can change your decision. Okay, so don't go for this surgery when you are not still have some under training or something like this.
Great. You go into the bullseye, because if it's very easy to think that Dr. Hani will say always go to OHGV if you're not ready, and you tell us the best thing to learn to this topic, and the message to go, that is, be prepared, be ready for all the outcomes, and also that right now, GERD after sleep, the evidence shows that we need to do Roux-en-Y, because right now Roux-en-Y is, at least today, the best option for GERD after sleep, but OGB can be an option. Gentlemen, any last thoughts, any final message before we leave?
Yes, you need to do a safe thing to the patient. You need to do the safest thing to the patient. This is your patient. He deserves the best. Okay. So now for our study, now we prove that the OHP is a simpler and easy, and they can achieve an equal result in these cases that we in the inclusion criteria we use. But you need to extend the follow-up. We need to extend the criteria to see even if it will say be safe for those with higher grade of reflux, with higher BMI, or with who we in the during follow-up will regain weight more than the others. So we need to extend our data, and we can have a more inclusion and more reflux grade, and to study well before the anatomy and the motility of the area that we are working on, to better choose a right surgeon. But for now, when you have a patient with GERD A, nothing more than this, you can do what you prefer. Okay.
Dr.
Okay.
Tresma?
Yes, well, I keep it more on the general term. I felt very honored when Dr. Hani contacted me to collaborate, and you see what can help and what can do if you bring two knowledges together. So I want to end with the fact that it is all teamwork, and we need to collaborate with each other, because teamwork is an abbreviation. It stands for together, everybody achieves more. And there is no I in team. And this proves that when you try to collaborate, not only within one hospital, but also between hospitals, we do it all for the patients. So let's work together to achieve that.
And for that, I want to congratulate you on behalf of Ipso, and on my personal behalf, congratulate you on this collaboration and this teamwork, because it's not seen very often, and it would work very well. So thank you for your time. Thank you for your excellent work. And remember, to our audience, this presentation was recorded. You can see it on your Ipso channel on our Virtual Academy. One more time, thank you, Dr. Bartolesma. Thank you, Dr. Mohamed Hani. And we'll see you again in our next Ipso Journal Club. Have a great day. God bless you. And thank you. Good day.
Good day.
Thank you for moderating, Sebastian, Dr. Sebastian. Thank you.